Hi there, my name is Will Niven. I'm an EM consultant working at the Homerton University Hospital, and I'd like to talk to you today about how to critically appraise a diagnostic test study. So let's start by outlining some of the objectives. Basically, I'd like you to be able to critically appraise a diagnostic paper, particularly with respect to knowing the main questions that you might need to ask when appraising such a paper, to have an idea of the basic stats that are involved in diagnostic papers, and then to help you develop a strategy for deciding if the paper is actually relevant to your practice. Now, with everything, we need to have a structured approach to the appraisal of diagnostic papers that allows you in each of the following sections to be able to make certain inferences on the overall validity, accuracy, and applicability of the diagnostic paper to your practice. So it all starts with the title. This should give you a clear idea of what the study is looking to answer, and if it doesn't, it's not really a great sign. So you need to look into the introduction or background section sometimes to get a bit more information. Here is an example of a good title, and here is an example of perhaps not quite such a good one. No offense if anyone viewing this wrote the article, I'm sure it was very good. So, in the intro, you really need to have, you'd like to see a clear topic outlined within the first sentence. So, for an example, early establishment of the level of crazy in patients who present to the ED has long belevelled emergency physicians. Now there should be some context of the previous research. So, Bundy et al. In 2002 explored this issue and concluded that the wearing of sunglasses is a good test to allow for rapid detection of low acuity and unnecessarily odd behaviour. Recent evidence from Manson has postulated the unbidden offering of a pain score or suggestion of a high pain threshold may be a better and more sensitive surrogate test. Finally, the introduction should state a clear aim or rationalisation for the research. In this paper, we compared sunglass wearing to a composite measure of unbidden pain score offering or suggestion of a high pain threshold to the gold standard test, namely opinion of treating consultant within 30 seconds of initial history that the patient was a bit nuts. The methods or methodology section really looks at the how aspect of the study. In other words, how was the study conducted? How was the sample size calculated? How were patients recruited? How were they followed up for the outcome of its interest, etc. You want to know if this study is practical and potentially repeatable according to the explanation given in this section, and it will to some extent be answered by whether or not there's a PCOT type question that is addressed. So, PCOT stands for Population Intervention Control Outcome and Time Frame. So a population could be adults with suspected ischemic heart disease. Intervention in the context of diagnostic papers, this is generally the new test under question, for example, heart fatty acid binding protein. The control is normally the gold standard test that is in existence, so it could be troponin I. The outcome should clearly state what the outcome of interest is, such as myocardial infarction, revascularization, or death at 30 days, otherwise known as MACE. And then they should give some idea of the time frame, for example, 4 months over which the study was conducted. Moving on to population, the methodology should kind of give you some idea of the setting, for example, a busy inner city district general hospital. The authors should mention how the sample size was calculated and what the inclusion and exclusion criteria were, how recruitment took place, for example, between 7 a.m. to 7 p.m. weekdays over 4 months. And then the next question is, do the patients recruited represent the population of interest? So if you're conducting a study on patients who present with chest pain to the emergency department, but only include patients who walk in through the front door, then you might be missing out on patients who've arrived by ambulance, thereby potentially skewing your data in favour of less acute patients. Gold standard is the best available test under reasonable conditions. So, for example, the gold standard test for the diagnosis of a type 1 myocardial infarction is coronary angiography that identifies intracoronary thrombus. Sometimes you may actually need to have a combination of tests, such as the so-called triple test for Down syndrome, which was for a long time the gold standard, now largely superseded by superior methods. So in summary, it could be a single accurate test, or it could be a combination of tests. Sometimes the reference standard used will not be the gold standard because the test is too tricky to do. And a really good example of this would be venography for DVT. We've therefore got to think of another test and develop we need to have a good think and develop a reference standard that's almost as good, and in this case it could be a Doppler ultrasound. The problem when you're not using the gold standard test is that there are always going to be some false negatives, i.e. people who have the disease in question but happen to have a negative test, and we need to find some way of identifying them, and this is the main reason we often rescan in the case of individuals with a high well score and a positive dimer, because that's going to cut down the number of false negatives that might have been missed the first time round. The reference standard is really vulnerable to two kinds of bias that you need to be on the watch out for. And the first is known as workup or verification bias. In this situation, the diagnostic test under evaluation determines which reference standard is used. So a good example would be that if the well score is low, we tell people to get a dimer, and only if that is positive do we do a CTPA. Whereas if the well score is high, everybody gets a CTPA irrespective of the dimer being performed or not. The result is that you only use the gold standard CTPA to verify the results of those with within a select group of patients being high risk for PE. So you might actually overestimate the sensitivity of your test and underestimate its specificity. We'll talk a bit more about sensitivity and specificity later. Ideally, everyone should get the same test, but because this doesn't happen, this often doesn't happen because a gold standard test is expensive, invasive, or potentially harmful, making it unethical to perform on everyone. And the other form of bias is known as incorporation bias. And this is when the diagnostic test under evaluation forms part of the reference standard. So if you were evaluating cardiac markers for diagnosing MI, the reference standard will often include a cardiac marker in the definition of the MI, such as troponin. Blinding is really about ensuring that the person measuring or interpreting the diagnostic test under evaluation is blinded to the reference standard, so that their interpretation of the test is not biased by the results of the reference standard, and vice versa. So, say we wanted to evaluate whether or not the ECG was really such a good indicator of MI, then we couldn't have the person reading the ECG knowing what the result of the gold standard angiogram was, as this could bias their interpretation. Inter-observer agreement, or error, is an important aspect of diagnostic tests, and this really answers the question, are the results similar when measured by different clinicians? Now, when you have an objective measurement like serum troponin that is numerical and has clear cutoff values, then there is usually perfect agreement between operators. If you have something that relies on interpretation, for example, whether or not there's clot in the deep venous system whilst performing a Doppler ultrasound, then this is obviously vulnerable to subjective variables like operator technical skill and experience. So in general, the more the clinicians agree on the measurement of the test in question, the more reliable the test is. Agreement is classically measured using kappa or weighted kappa scoring, where 1 shows perfect agreement and 0 shows no agreement whatsoever. The following are important terms in diagnostic papers, and this is the bit you need to concentrate a bit more about because it's the most technical part of this brief talk. Sensitivity and specificity tell us about who has or who has not got the disease. Positive and negative predictive value tell you more about who has a positive or a negative test. Likelihood ratios tell us about how much more likely the diagnosis under question is after a positive or negative test. And then ROC curves, we'll go into that as well a bit later on, probably easier to understand pictorially. Sensitivity is the proportion of patients with a positive test. Really nice and sensitive tests will detect a high proportion of patients with the disease by having a positive test. So if we had a test that had a sensitivity of 85%, then the corollary of that is that 15% of the patients with the disease will have a negative test, and that really wouldn't be good enough for us to rule out the disease. A better example of a sensitive test is troponin, which will always rise in the context of myocardial infarction because it is so sensitive, and as a result it's been included in the definition of MI. So a negative troponin rules out the diagnosis of myocardial infarction. So herein lies the value of sensitivity. A sensitive test helps you to rule the disease out. So SN for sensitivity, out, snout. Sensitivity is the proportion of patients with the disease who have a positive test. So we divide all those who have the disease, who have a positive test, in other words, the true positives, by the total number of people who actually have the disease. So that's the true positives and the false negatives. You can then times it by 100 to give a percentage. So what is specificity? Well, specificity is the proportion of patients without the disease who have a negative test. Once again, if we take the case of troponin, it has a sensitivity of about 100%, but it has a specificity of about 50%, meaning that having a positive troponin does not necessarily mean that you've had an MI. So we cannot necessarily rule the diagnosis in if, by contrast, we take a test like CT for the diagnosis of subarachnoid hemorrhage after 12 hours. We know that if we see blood on the scan, that it is close to 100% specific, and we can rule the disease in this context. However, the sensitivity is below 95% after this time, hence the reason that we're still doing LPs for xanthochromia. So a specific test will be good for ruling a disease in because it has a low proportion of false positives and a high proportion of true negatives. Numerically speaking, specificity is measured by dividing all the true negatives, so those who do not have the disease and have a negative test, by all the true negatives plus the false positives, those patients who have a positive test but don't actually have the disease. Thus, if you performed a CTPA on 100 patients who did not have a PE, and 2 of the tests were positive and 98 were negative, then you could say that CTPA has a specificity of 98%. Positive predictive value is essentially the proportion of patients with a positive test who truly have the disease. The big issue with it is that it alters with the prevalence of disease, and the positive predictive value increases as the prevalence increases. In this 2x2 table, you can see that the positive predictive value can be worked out by dividing all those who have the disease and a positive test, the true positives, by all those who have a positive test. So that's true positives and false positives. In order to show how the positive predictive value changes, you need to take a theoretical example, say of 1,000 patients, in which the test is 90% sensitive and 90% specific. Now watch in this next slide how if we substitute values for a 5% prevalence and then for a 10% prevalence, the positive predictive value will change. So really slowly now. If I have 1,000 individuals and a test that is 90% sensitive and 90% specific, I have shown in the example on the left what will happen to the positive predictive value if we take a prevalence of 5%. There are 45 people who have the disease and a positive test, true positives, and 95 individuals or people who do not have the disease but still have a positive test. We then divide the 45 true positives by all the people who have a positive test, and we get a proportion of 0.32, which when multiplied by 100 gives us a positive predictive value of 32%. On the right, I have done the same calculation, only with a prevalence of 10%. And you can see here, what you can see here is that the higher the prevalence, the higher the positive predictive value. Negative predictive value. This is quite simply the proportion of patients with a negative test who truly do not have the disease. And just like the positive predictive value, the negative predictive value will alter with the prevalence of disease. However, in this case, the less prevalent the disease, the higher the negative predictive value. Again, from a mathematical point of view, we calculate the negative predictive value by dividing the number of true negatives, D, by the total number of people with negative tests, that's C and D. To use a simple real-life illustration of how the negative predictive value might be put to clinical use, if we take the case of the Wells score and D-dimer, the low-risk group will have a much lower prevalence of DVT or VTE than the high-risk group. And then if we use the D-dimer in this context, then we have a tool that has an excellent ability to rule out the possibility of deep vein thrombosis or VTE. So to summarize at this point, the more sensitive your test is, the better it is at ruling the disease out. The more specific your test is, the better it is at ruling it in. Sensitivity and specificity remain the same no matter what the prevalence is, in contrast to the positive predictive value and the negative predictive value, which alter with prevalence. The higher the prevalence, the better the positive predictive value. The lower the prevalence, the better the negative predictive value. So now that you've worked out the sensitivity, specificity, positive and negative predictive values, it's important that you add up the numbers in each of the 4 cells above to confirm that it equals the total number of participants the authors say were enrolled, because you never know what jiggery-pokery you might find. Moving on to likelihood ratios. Basically, this is how likely it is that we would find a positive test in someone with the disease or a negative test in someone without. It really tells you how diagnostically useful the test is. It's a number between 0 and infinity, and if it's greater than 1, it indicates that the information increases the likelihood of the diagnosis in question, and if it's less than 1, it indicates that the likelihood of the suspected diagnosis is less or lessened after the test. So from a statistical point of view, the likelihood ratio of a positive test is given by sensitivity over 1 minus specificity. The likelihood ratio of a positive test is how much more likely is a positive test to be found in a person with as opposed to without the disease. And the likelihood ratio of a negative test is the inverse of that. So it's 1 minus sensitivity divided by specificity. And that tells us how much more likely a negative test is to be found in a person without as opposed to with the disease. So with values of with a likelihood ratio value of 0.5 to 2, there's not really much you can say. But if someone's got a likelihood, if your test has got a likelihood ratio of 0.2, then that markedly decreases the likelihood and could potentially rule the disease out. And if you get a value of more than 5, then that markedly increases the likelihood and could in fact be diagnostic of the index condition. ROC curves are important to understand if we're to understand the value of the test in clinical practice. In this diagram, the blue curve represents a standard distribution of values for a particular test in a well population, and the red curve represents the standard distribution for values of a test for individuals who have the disease in question. The area of overlap signified in purple represents the point at which the test is inaccurate. And if we are to draw a line signifying the test cutoff value, we can see the purple area to the left of that line represents the false negatives, and the area to the right represents the false positives. I'll give you a few seconds just to work that out. So if we move that test cutoff line to the left, we would have a sensitive test that picked up everyone with the disease. But unfortunately, we'd also pick up a lot of people who didn't in fact have the disease but were false positive. So the test says that they have the disease, but in actual fact they're well. And if we instead move the test cutoff line to the right, we would then have a very specific test, but we would get a lot of false negatives and miss out some of the people who actually have the disease. So in ROC curves, what we do is we essentially plot the sensitivity against 1 minus specificity, or the false positive rate. And we take the cutoff values for the test and plot them on a line in which we, as I say, map sensitivity on the y-axis against 1 minus specificity on the x-axis. And to use an example of T4, if we used a T4 level of 9 micrograms per deciliter as being the level below which we diagnosed hypothyroidism, we'd pick up nearly everyone with hypothyroidism. But because the level, whilst low, could be normal in euthyroid patients, we would end up having a lot of false positives. And if we took a cutoff value of 5, then we'd pick up everyone with hypothyroidism, but we might miss some people who actually had the disease or were falsely negative. So from this curve we can see that 7 is the Goldilocks point, where you have the best trade-off between sensitivity and specificity. And in general with ROC curves, the closer the test is to the left border and the upper border, the more accurate your test. And the closer the test is to the 45-degree linear line, the less value your test is. Now, for those of you that are extremely technical, what you can see from here is that the slope of the tangent line at a particular cutoff point gives you the likelihood ratio that was discussed in earlier slides. So now take a deep breath and relax. The stats are over. The final part of the appraisal exercise is to really start synthesizing your assessment of the results in order to make a conclusion about the overall validity of the study, which can be divided up into 2 sections. Firstly, the internal validity, which is whether or not you think the study is a reflection of the truth in the context in which it has been conducted. That is, do you agree with the findings of the study after going through the introduction methods, results, and discussion? Secondly, is the study generalizable to other, and in particular to my clinical environment or context? So if there's a study carried out at the Mount Sinai that is showing CT angiogram could be conducted on all patients with suspected subarachnoid hemorrhage because of its superior sensitivity, you might conclude that this might not necessarily apply to your rural ED in Marandera, which is where I grew up in Zimbabwe, where you're operating with a donated 32-slice scanner decommissioned in Sloan Kettering in 1985. So in summary, the internal validity refers to the robustness of the study in question that you've read about in your paper, and the external validity is the extent to which results of the study can be extrapolated to a wider population. You might want to ask yourself cheekily what you would have done differently, and whether or not this will actually change your practice. So the first question is it important? Some new tests might be able to accurately diagnose rhinovirus in sufferers of the common cold, but it's probably not that important to the general population other than perennial sufferers of man flu. The next is it applicable to your population in terms of demographic, in terms of gender, culture, linguistic variation? Is it a different setting? So EDs are different depending on whether they're rural, whether they're urban. They're different between different countries as well. And then we talk about the 4 B's of implementation. So are there any barriers associated with the new diagnostic test? So could patients be potentially harmed by this new test? Beliefs. So you need to get buy-in from your staff, and you often need to get buy-in from patients if there's a new test in question, particularly if it causes discomfort or pain to patients. What's the burden of disease or the incidence of the disease that your diagnostic test might be looking to rule in or rule out? If the incidence of a particular disease is really low and you only get a couple of cases of this particular disease per year, then you might ask yourself whether or not it's worth investing in a test just to rule in or rule out that particular disease. And then budgets. What's the cost of the new test? And if there's a massive difference in cost, and that your new test is way more expensive than the existing one, then you'd need to be able to demonstrate why superior sensitivity, specificity, or positive and negative predictive value are such that it justifies the cost in question. Classically, in the critical appraisal paper in the FR Chem, you'll be given a question like this to answer. The chief executive of your hospital has read the title of the paper and asks you about using the results to improve care in the hospital and avoid admissions. On the basis of the evidence in the paper, outline an argument for or against local implementation. And as we've discussed a little bit earlier over there, this is the point at which you look at the trade-off between internal and external validity, and you bring to bear the appraisal tools that you've just learnt in this brief lecture. Whether or not you're actually doing an exam, this kind of question is a useful one to answer for yourself at the end of reading a paper, because it'll affect whether or not you think it's worth implementing a change in your practice, your department, or your hospital. So in summary, you need to decide whether this paper at the beginning is relevant to your practice. Has the gold standard been outlined, or a suitable reference standard? Has there been blinding of the people reading the test? What was the inter-observer reliability of that particular test? The 2x2 tables and all the various statistical terms that we've gone through, likelihood ratios, the conclusions reached, are they in line with the results? And then finally deciding whether or not you're going to bring about a change in practice after actually having appraised the paper. So I'm now shortly going to upload a paper onto Synapse, which I'd like you guys to read prior to the core academic day on the 21st of June. And I look forward to seeing you on that day and tearing the paper apart. Have a good day.